I want you to imagine, just for a second, living in ancient Greece. Like, if someone committed a crime, or if
Mm.
they were enslaved, or even considered a traitor to the state, they weren't just given a harsh sentence.
Right. It wasn't just jail time.
Exactly. They were physically marked, like a
Yeah.
brand was literally burned or, cut right into their skin. And the Greek word for that physical burn, stigma.
Wow.
Yeah, it was a broadcast to the entire world that basically said, this person is ritually polluted. Avoid them.
Well, it wasn't just a metaphor back then. I mean, it was a very real, very physical warning sign.
Yeah.
It was completely designed to isolate someone from society.
Mm.
It served as this permanent visual boundary between who belonged to the community and who was just completely cast out.
And today we are taking a deep dive into how those literal physical burns have evolved into invisible social brands.
Which can be just as damaging, really.
Oh, absolutely. And specifically, we are looking at this through the lens of mental illness. So our mission today is breaking down the barriers of stigma, understanding how it operates on this hidden, almost mechanical level in our daily lives, and uncovering the deeply counterintuitive science of how to actually reduce it.
Because, I mean, we are looking at a system that has moved from a literal mark on a person's body to this incredibly complex web of social dynamics, institutional policies, and even how we view ourselves.
Right. And to do this, we are pulling from a pretty great stack of sources. We've got foundational sociology, some landmark psychological experiments, and modern public health data.
That's a lot of ground to cover.
It is. Okay, let's unpack this. Because before we get into the psychology of how our brains process all of this, I want to know how society collectively agrees to apply these invisible marks in the first place. Like, who actually gets to decide what is or isn't a stigma?
Well, to answer that, we really have to look at the work of a sociologist named Irving Goffman. Because in 1963, he essentially took this ancient Greek concept and gave it its modern academic shape.
Okay.
Yeah, he wrote this foundational text called Stigma, Notes on the Management of Spoiled Identity.
Spoiled identity. Man, that is a really heavy phrase.
It is, yeah. And it's actually the core of his entire theory. Because Goffman argued that a stigma is an attribute that is so deeply discrediting, it reduces a person from being, a whole and usual person to a tainted, discounted one.
So it's not just a flaw.
Exactly. It's the difference between someone saying, you made a mistake, and someone saying you are a mistake.
Yeah.
He argued that this spoiled identity changes the fundamental rules of how people interact with you.
And the sources mentioned, he broke this down into 3 specific categories, right? Like, he didn't just lump every outcast into one big bucket.
Right. He categorized them based on how society perceived the origin of the mark. So, first, he identified abominations of the body.
Meaning physical stuff.
Yeah, physical deformities or visible disabilities, things that could be seen instantly. Then second, he defined tribal stigma, which were traits tied to race, nation, or religion that were passed down through generations.
Got it. And the third category is the one that really anchors our deep dive today. He called them blemishes of individual character.
Yes.
Which is where society placed mental illness along with addiction or having a criminal record.
Well, and you have to remember the context of the 1960s here. I mean, the prevailing cultural assumption back then was that a mental health struggle was a sign of a weak will or, moral failing or dishonesty.
Like it was your fault.
Exactly. If you couldn't just snap out of it, society viewed that not as a medical issue, but as a severe flaw in your fundamental character.
Right.
So Goffman's work was revolutionary because it documented how individuals tried to navigate daily life while managing this immense burden of a spoiled identity.
But, reading through the modern sociology in our sources, it seems like Goffman's theory, as brilliant as it was, had a massive blind spot.
Oh, definitely.
Because he treated stigma almost like eye color, like it was just this fixed attribute a person carried around in a vacuum.
Right. He focused almost entirely on the individual. But if we fast forward to 2001, sociologists Bruce Link and Joe Phelan published a huge critique.
Okay, what did they say?
They argued that Goffman's framing was way too narrow. They redefined stigma not as an attribute, but as a social process.
A process.
Yeah, they broke it down into a chain reaction of 5 steps. First, society notices and labels a human difference. Second, society links that label to negative stereotypes. Third, we create an us versus them separation.
Right, the dividing line.
Exactly. Fourth, the labeled person experiences status loss. And fifth, that leads to direct discrimination.
But they also argued that all 5 of those steps could happen without actually creating a true stigma unless you add one specific overarching ingredient, right? Power.
Power. Power is the engine of the entire process.
Yeah.
Lincoln Phelan pointed out that stigma only produces its devastating, life-altering effects when the group doing the labeling holds the social, economic, or political power to actually make those labels stick.
I was actually trying to visualize this power dynamic earlier, and it reminds me of a workplace.
Oh, how so?
Well, imagine a patient is in a room with the psychiatrist and calls the psychiatrist cold or unfeeling. The patient is applying a label and a stereotype, right?
Right.
But it's kind of like a summer intern insulting the CEO. Like, it might bruise the CEO's ego, but the intern doesn't have the institutional power to ruin the CEO's career or deny their health insurance or force them into treatment.
That makes total sense.
But if society, backed by the medical and legal institutions, labels that patient crazy or unstable, that is like the CEO blacklisting the intern.
Yes, the structural weight is completely asymmetrical. If we connect this to the bigger picture, that analogy perfectly captures why Lincoln Phelan's focus on power was so vital.
Because it's not just a two-way street.
No, it shifted our understanding of stigma from just being, a personal problem to being recognized as this massive moving system.
Right.
And modern researchers, like the psychologist Patrick Corrigan, look at this system and break it down into 3 levels. You have public stigma, which is the general public's prejudice. Self-stigma, where a person internalizes those beliefs and turns them against themselves, and structural stigma, which is baked into laws, institutional policies, and corporate culture.
So if you are listening to this right now, I want you to think about the last time you walked onto a crowded subway train or into a really busy room. Your brain immediately starts making these snap judgments about who is safe, who to avoid, who belongs.
It's automatic.
Right. So how much of that primal instinct is driving the structural system we are talking about?
Well, if you strip away the academic sociology, that is exactly the cognitive shortcut driving stigma. As humans, we are basically wired to categorize our environment instantly for survival.
Just a quick threat assessment.
Exactly. And Corrigan maps this cognitive process in 3 stages: stereotype, prejudice, and discrimination.
Okay, break that down for me.
So a stereotype is just a shared cognitive belief, for example, the totally false belief that people with mental illness are inherently dangerous.
Right.
That belief triggers a prejudice,
Yeah.
which is an emotional reaction, usually fear or anger. And that emotion instantly dictates discrimination, which is the physical behavior.
Like crossing the street to avoid someone.
Yes, or tossing their resume straight in the trash.
And this all happens in fractions of a second.
Oh, absolutely. Long before your conscious, logical reasoning even engages.
But how much does a label actually change reality? Like, if you take someone who is completely healthy and you just slap a really powerful institutional label on them, do people still see the healthy person, or do they only see the label?
That is the million-dollar question. And to answer that, we have to look at one of the most controversial and revealing studies in psychological history.
The Rosenhan experiment.
The Rosenhan experiment, published in the journal Science in 1973. The psychologist, David Rosenhan, wanted to test exactly what you just asked. Can psychiatrists actually distinguish the sane from the insane inside a psychiatric hospital?
Which seems like a basic requirement for a hospital.
You'd think so. So he sent 8 totally healthy volunteers, he called them pseudo-patients, to 12 different psychiatric hospitals across the United States.
And the setup for this is incredible, because their only symptom was that during the intake interview, they claimed to hear a really vague voice saying the words empty, hollow, or thud.
That's it.
That is literally it. Just those 3 words.
Just those words. And based entirely on that brief intake, all of them were admitted.
Wow.
And here's the kicker. The moment they were admitted to the wards, every single one of these volunteers dropped the act.
They stopped faking it.
Completely. They behaved normally. They told the nursing staff the voices were totally gone. And they were cooperative and calm.
Wait, so they reverted to being their normal selves immediately? Did the doctors notice? Like, how long were they kept there?
They were kept in these locked wards for anywhere from a week to 7 weeks.
7 weeks.
Almost 2 months in one case. And not a single hospital staff member ever identified them as healthy or sane. In fact, they were all eventually discharged with a diagnosis of schizophrenia in remission.
So the label stuck permanently.
Permanently.
You know, my favorite, or I guess maybe the most disturbing detail from the study is about the note-taking.
Oh, the writing behavior?
Yeah, because These volunteers were obviously taking notes for the experiment while they were sitting in the ward, but the nursing staff actually recorded this totally normal activity in their medical charts as patient engages in writing behavior. Like, they pathologized taking notes.
Right, because once the label schizophrenic was attached by an institution with power, all ordinary behavior was reinterpreted through the lens of that disease.
It's terrifying.
It is. The doctors and nurses weren't necessarily malicious, Their perception of reality had just been entirely hijacked by the label.
Which actually makes me want to push back on something here. Because if ordinary note-taking is seen as a psychiatric symptom just because a doctor wrote a word on a clipboard, doesn't that mean the sociologist Thomas Scheff was right?
You're referring to his labeling theory from 1966.
Yes, exactly. Because Scheff proposed that being formally diagnosed and treated as mentally ill actually produces the symptoms.
Right. He argued that people just learn to play the social role they've been assigned by society.
Right. So if a hospital can invent symptoms out of thin air, like writing behavior, is the disease entirely in the eye of the beholder? Like, is it all just a social construct?
I mean, it is a very compelling question, and Scheff's theory gained a lot of traction back then because it challenged institutional authority. But throughout the 1970s, another sociologist, Walter Gove, pushed back on this heavily.
Why? What did Gove say?
Gove pointed out that Scheff was completely overstating the role of the label, and in doing so, he was ignoring the biological reality of the disorders themselves.
Because ignoring the biology minimizes the actual illness.
Precisely. Gove basically argued that while the Rosenhan experiment is this staggering indictment of institutional bias, dismissing the underlying biological reality of psychiatric disorders ignores the very genuine, often agonizing suffering of the illness itself.
Right. It's not all made up.
No, schizophrenia, bipolar disorder, severe depression, these aren't illusions created by a doctor's clipboard. The distress is very, very real.
So to plunk simply, Link and Phelan eventually came up with the modified labeling theory. So if the biological illness is a fire, society's label doesn't start the fire. But once the label is applied, it acts like a massive bucket of gasoline thrown onto it.
That is an excellent way to conceptualize it. The label doesn't cause the original illness, but the rejection, the lost opportunities, and the self-stigma that follow the label, all of that adds immense, crushing suffering on top of the baseline illness.
Okay, so if the label is the gasoline, the logical next step for society is to figure out how to stop throwing gasoline on the fire, right? We need to destigmatize the label. And intuitively, if you think back to Goffman, the stigma historically came from people thinking mental illness was a blemish of character, a moral failing.
Yes.
So the obvious solution is to just teach the public that mental illness is just a biological disease, like a chemical imbalance. It's a broken brain, not a broken character.
I mean, it sounds incredibly logical. And for decades, that was the default public health message. Mental illness is an illness like any other. The entire goal was to remove blame from the individual.
But the data in the sources shows this strategy completely backfires.
It does.
How is that possible? I mean, if I know a condition is a chemical imbalance, I know it's not their fault.
Yeah.
Shouldn't stigma plummet?
Well, it is known in the literature as the double-edged sword of biogenetic framing.
Okay.
The research shows that the strategy did achieve its primary goal. Technically, people were significantly less likely to say someone brought the illness on themselves. But the uncomfortable, totally counterintuitive finding was that this biological framing simultaneously increased public fear. It increased perceptions of dangerousness, unpredictability, and this really strong desire for social distance.
Because it makes the condition seem permanent and like fundamentally alien. Here's where it gets really interesting. Think about it like reading a clinical biology textbook about a grizzly bear.
A grizzly bear, okay.
Stick with me. You learn about its jaw strength, its territorial instincts, its brain chemistry. That textbook explains exactly why the bear acts the way it does, so you don't blame the bear for being a bear.
Right.
But knowing all that biological data still makes you want to stay as far away from it as humanly possible.
Yes, that is exactly the mechanism at play here. When you frame a human being solely through the lens of a broken brain or genetic determinism, you accidentally strip away their relatable humanity.
Wow.
Yeah, memorizing diagnostic facts and neurochemistry does almost nothing to dissolve social stigma.
So if biology lessons backfire, what actually works?
What actually works is called the contact hypothesis.
The contact hypothesis.
Yes. This theory was originally developed in the mid-20th century by the psychologist Gordon Allport to explain how interracial contact reduces racial prejudice.
Oh, interesting.
And Patrick Corrigan and his colleagues later took Allport's theory and applied it to mental health. What's fascinating here is they found that direct, structured, personal contact with someone who has lived experience of mental illness shifts attitudes far more reliably than any public education campaign focused on statistics or biology.
Which we see put into practice beautifully by the National Alliance on Mental Illness, or
Yeah.
NAMI,
Exactly.
because they run this program called In Our Own Voice. And instead of sending a psychiatrist with a PowerPoint full of brain scans to like a local police department or a high school, they send people in recovery.
Real people.
Real people who just stand up and describe their life, their darkest moments, their recovery, and just their ordinary humanity.
And this isn't just effective in small community rooms either. We have data on a massive national scale from England.
Oh, right, the Time to Change campaign.
Yes. Between 2007 and 2021, England ran one of the most ambitious anti-stigma campaigns in history. They didn't just buy billboards saying "be kinder." They systematically trained thousands of people with lived experience to speak in their communities, in town halls, and in corporate workplaces.
So they paired the mass media visibility with this grassroots contact-based approach.
Exactly.
And the metrics they tracked weren't just asking people, do you feel nicer about mental illness? They actually tracked behavior.
They tracked what sociologists call intended social distance.
Okay, what does that mean?
They measured whether the public was more willing to work alongside someone with a mental illness, or rent a room to them, or have them marry into their family.
That's real-world stuff.
Very real. And over 14 years, independent tracking showed measurable, statistically significant improvements in those real-world behaviors.
Wow.
It proved that stigma is not a fixed, immovable force. It responds to sustained, human-centric connection.
Though the sources do note that public attitudes around the most severely feared diagnoses, like schizophrenia, were much slower to shift than attitudes about depression or anxiety.
Yeah, unfortunately. The more the media associates a specific diagnosis with erratic behavior, the harder it is for the contact hypothesis to break through that prejudice.
Which actually brings us to the invisible harms. Because when we talk about public campaigns, there is this massive misconception that stigma is just about mean words.
Right, like name calling.
Yeah, people think stigma is just someone calling you a name on the street. But in reality, it operates silently to destroy lives. Like, take the violence myth, for example.
Oh, the violence myth is deeply entrenched. Because every time there's a mass casualty event on the news, the immediate narrative shifts to mental illness.
Every single time.
But the research consistently finds the exact opposite is true. People with serious mental illnesses are far more likely to be the victims of violence than the perpetrators.
Oh, really?
Yes. Severe mental illness alone accounts for a tiny fraction, often cited as around just 3 to 4% of overall societal violence. Yet the stereotype persists, driving that fear and social distance we talked about.
And then you have the harm that happens when no one else is even in the room. Patrick Corrigan calls it the why-try effect.
Self-stigma.
Right. This is the endpoint of self-stigma. This is when a person absorbs the public's prejudice so deeply that their self-esteem and their belief in their own capability just evaporate.
It's heartbreaking.
They think society says people with my label are incompetent, so I must be unworthy. And they literally give up on applying for jobs, pursuing romantic relationships, or seeking independent living before they even try.
It is a devastating behavioral consequence. The person essentially does the work of the discriminator for them.
Yeah.
And this scales up to the institutional level, too, what we defined earlier as structural stigma. I mean, think about how healthcare has historically been funded. For decades in the United States, insurance policies reimburse psychiatric care at drastically lower rates than physical health care.
Which is just crazy to think about now.
Right. They would cap the number of therapy visits you could have while offering unlimited visits for a chronic physical illness like diabetes.
So it was literally baked into the math of the institutions. It broadcasted a clear message. This illness is less legitimate.
Yes.
And it wasn't until the Mental Health Parity and Addiction Equity Act of 2008 that the government finally forced insurance companies to begin treating mental and physical health benefits equally.
Long overdue.
Absolutely. So what does this all mean? When we look at the why-try effect and we look at those historical insurance policies, is it accurate to say that a silent, polite insurance adjuster working quietly at a desk could actually cause more stigmatic harm than a person yelling a slur on the street?
Well, this raises an important question because it depends on how you measure harm. But structurally.
Yes, truly, yeah.
The person yelling a slur is engaging in interpersonal discrimination, which obviously causes immediate emotional pain. But the polite insurance adjuster, simply by executing a biased policy, is participating in structural stigma. And structural stigma creates what public health experts call the treatment gap.
The treatment gap, that's the difference between the number of people who desperately need mental health care and the number who actually receive it.
Exactly. Stigma, whether it is the fear of judgment from family, the fear of a permanent label on a medical record, or the literal lack of equitable insurance coverage, is consistently cited as one of the leading reasons people delay or avoid treatment altogether.
And we are talking about delaying treatment for years.
Years, sometimes a full decade after symptoms first begin.
A decade.
And that delay is catastrophic. It turns manageable early-stage conditions into severe, disruptive crises that derail education, destroy careers, and tear families apart. So stigma isn't just an issue of empathy or hurt feelings. It is a massive, measurable public health emergency that actively prevents healing.
The raw power of institutions to manufacture this harm is just undeniable. But the sources also highlight one historical example that proves institutions also have the power to erase it.
Oh, the DSM.
Yes. Until 1973, the American Psychiatric Association's Diagnostic Manual, the DSM, officially classified homosexuality as a mental disorder.
It carried the full, unquestioned weight of medical institutional power.
Right. It provided a quote-unquote scientific justification for discrimination, job loss, and social ostracization.
But sustained, fierce activism forced the psychiatric community to examine the complete lack of scientific basis for that label.
Right, and in 1973 they removed it. And while it didn't end homophobia overnight, it shows how removing an institutional label can fundamentally reshape both public attitudes and self-stigma for millions of people. It took away the gasoline.
It proves that these labels are not inherent truths of nature. They are agreements made by society, and society can choose to tear those agreements up.
Which really brings us full circle on our journey today, because we started in ancient Greece with physical brands burned into skin, and we've seen how that concept evolved into Goffman's spoiled identities and Link and Phelan's systems of structural power.
It's a long history.
It really is. And we learned that trying to fix the problem by just teaching the biology of a broken brain actually backfires, increasing fear rather than empathy.
Right, and we learned that the real antidote is the contact hypothesis, human connection, structured interaction, and genuinely listening to the lived experiences of those in recovery.
It just makes you realize that everyday language really does matter. Like when you casually call a situation crazy or use a diagnosis as an adjective, or when you choose whether or not to listen to someone's lived experience, you are interacting with the levers of this system.
You are. And as we close today, there's one final, somewhat uncomfortable layer to this that is crucial to consider. Goffman also introduced a concept called courtesy stigma.
Courtesy stigma.
Yeah, this is stigma by association. It is the stigma that spreads like a shadow to the family members, the friends, or the partners of a stigmatized person. Society basically begins to judge them simply for being adjacent to the label.
So it's contagious.
It is socially contagious. And it leaves us with a really difficult question to reflect on. If stigma spreads by association, how much of our own social behavior is secretly dictated by self-preservation? Who we choose to date, who we befriend, who we publicly advocate for. How much of that is driven by the fear that someone else's mental health label might rub off on our own social standing? Are we participating in the isolation of others simply to protect our own unspoiled identity?
Wow.
Furthermore, when we tried to help by pushing the biological broken brain narrative for decades, were we really trying to understand them, or were we just trying to put them in a neat clinical box so we wouldn't have to engage with their humanity?
That is a deeply necessary question to leave with. Our good intentions don't always dismantle the barrier. Sometimes they just reinforce it from a safer distance. Thank you for joining us on this deep dive into the invisible marks we place on each other and how we might finally start erasing them. Until next time, take care.